Hi everyone. This particular episode is based on the topic congenital chest wall deformities. The material is taken from Zabiston Textbook of Surgery, 21st edition, and we will be covering this topic with the help of a lot of MCQs, a lot of picture-based questions. So let us start. Let's look at the first question, that is identify the above deformity, that is pictures here. Identify this deformity. We have to identify this deformity. Is it pectus carinatum? Is it pectus excavatum? Poland syndrome or a cleft sternum? What is this? So we need to understand that there are a couple of chest wall deformities. In a particular deformity, the sternum, if this is the manubrium sterni, this is the body, and this is a xiphoid process. Okay, manubrium sternum, the body, and the xiphoid process. If the body of the sternum goes inwards towards the vertebral column, which is present dorsally or posteriorly, the vertebral column, if this body of sternum goes towards the vertebral column like this, then this is called as pectus excavatum. And if body of the sternum goes away from vertebral column and projects outwards away from the vertebral column, then this is called as pectus carinatum. So this deformity, where the body of the sternum projects inwards towards the vertebral column, is called as pectus excavatum. And in which the body of the sternum, or the sternum, any part of the sternum, projects outwards away from the vertebral body or vertebral column, then this deformity is called as pectus carinatum. Pectus carinatum. Poland syndrome is congenital absence of chest wall structures, which can be subcutaneous tissue, can be pectoralis major muscle, pectoralis minor muscle, second to fifth ribs with cartilages, and can be hypoplasia or aplasia of the breast or the nipple areola complex. So those things are included in Poland syndrome. And cleft sternum is also bifid sternum, in which the two bodies of the sternum don't join together. They are called as the bifid sternum. All right. So we understand what each of these options actually mean. Now we try to answer the question by looking at the diagram. In this particular diagram, we can look at the manubrium sterni. This is the body of the sternum, and this is the xiphoid process right over here. Okay, this is the xiphoid process. We can easily understand that this sternum is going inwards. It's bent inwards and moving towards the vertebral column. Therefore, this particular deformity is pectus excavatum. Hence, the correct answer to this question is pectus excavatum. Now we move on to the next question. Which among the following is the most common chest wall deformity? This is a simple fact based question. So, obviously, we need to know the fact. So, the important fact is most common chest wall deformity is actually pectus excavatum, and the second most common chest wall deformity is pectus carinatum. Carinatum means that the sternum is going outwards, and excavatum once again means sternum going inwards. So sternum going inwards is the most common chest wall deformity. So the answer to this question, which among the following is the most common chest wall deformity, is actually pectus excavatum, and that is option B. We move on to the next question. Pick the incorrect statement regarding pectus excavatum. So this question tests our knowledge regarding pectus excavatum. We already know that pectus excavatum, that is the sternum going inwards. Yes, the sternum going inwards towards the vertebral column, and this is the most common congenital chest wall deformity. This particular deformity is actually more common in males. It's more common in males. We need to understand that most of these are sporadic. They are not familial. I mean, they can be familial varieties, but that is not the majority. Mostly they are sporadic. However, few can be familial. And we need to know the sternum goes inwards, and this inward means that is towards the vertebral column. Therefore, they are dorsally depressed. They are dorsally depressed. So with this knowledge in mind, we can answer this question. We can pick the incorrect statement. Option A, pectus excavatum is the most common congenital chest wall abnormality. I think we have discussed it, that pectus excavatum is the most common congenital chest wall deformity. So option A is the right answer. Option B, it is more common in males. We have discussed that it is more common in males, so that is also the correct response. Option C, they are usually familial. That is incorrect, because we have discussed that they are mostly, usually sporadic, few are familial. So the correct response to this question is yes, C, they are familial, because mostly they are sporadic. Option D, sternum is dorsally depressed, that is sternum going inwards towards the vertebral column, and that is correct. So we can move on to the next question. We have to identify this condition first, and after identification of the condition, we can answer the multiple choice questions. So we can take a look at this condition, and we can easily see that this is the nipple areolar complex, and there are the ribs over here. So this must be the area of the sternum. Okay, this must be the area of the sternum, and we can see that the sternum has gone inside, they've sunken inside, that is, they have gone inwards. And we also know that inwards or dorsal depression of the sternum is also called as pectus. Yes, excavatum. That is the inward or dorsal depression of the sternum. So now that we have identified the condition, we can go ahead and solve the MCQ. But before solving, we need to know certain facts. Fact number 1 is pectus excavatum is probably due to unequal growth rates of the lower ribs and costal cartilage. It is due to unequal growth rate of lower ribs and costal cartilage. Is it the right side which is affected or the left side which is affected? We have to remember that it is the right side which is affected more than the left side. We should also know that on the left side the heart is present, and her heart is shifted further towards left and rotated, right? And rotated. So right side is affected more than left, but on the heart, which is usually present on the left side, gets further pushed towards the left and gets rotated. If we take a look at the diagram below, this is the manubrium sterni, this is the body of the sternum, this is the xiphoid process, and this is the vertebral column. Let's say this is the situation 1, and the second situation, there is a greater depression, and this is the xiphoid, and this is the vertebral column. The situation 1 and this is the situation 2. We measure a distance, and this distance is called as the sternovertebral distance. What is it? Sternovertebral distance. So in situation 1, the sternovertebral distance is this much, and in situation 2, the sternovertebral distance is this much. So obviously in situation 2, the sternovertebral distance is lesser compared to situation 1, and we should know that in Sabiston textbook of surgery it says clear cut that is the most important prognostic marker is sternovertebral distance, which means lesser the sternovertebral distance, more is the severity. All right. Are these patients usually okay when they come to us, or they have some kind of heart problem or chest problem? Well, most of these patients are actually asymptomatic. Yes, they are asymptomatic. However, few patients will present with reduced exercise tolerance. So if we go on to solve the MCQ with this knowledge, we do get that if you look at option A, this condition is due to unequal growth rates of lower ribs and costal cartilage. That is correct. Note that it is lower ribs and not the upper ribs. It is unequal growth rates of lower ribs and costal cartilage. That is a correct statement. Predominantly, right side is affected. That is also a correct statement. Option C, severity is defined by reduction in sternovertebral distance. Obviously, more reduced the sternovertebral distance, more severe is the condition. And option D, majority of the patients have reduced exercise tolerance. This is wrong because majority of the patients are actually asymptomatic. However, few will present with reduced exercise tolerance. So this is the incorrect statement and therefore the right answer to this question. Now we can move on to the next question. A 50-year-old male comes to your clinic with complaints of breathlessness. A CT thorax was done and the CT thorax shows this particular condition. Okay, this is the CT thorax of the patient. Now the question is, which of the following are not indication for surgery for the above condition? Before reading at the options, we must understand few concepts. Remember that when the body of the sternum goes inwards, that is pectus excavatum, and when it goes outwards, that is carinatum. So in this particular case, if you look at the CT, we can see that the anterior chest wall is depressed and the sternovertebral distance is just this much. So it is a very severe case of pectus excavatum. And if you look at the heart, just here, it is compressed very much. That is why probably this patient has complaints of breathlessness. So CT thorax is done and a decision has to be taken whether the surgery should be done or not. As I have said, if we know that in case of pectus excavatum, most of the patients are asymptomatic. Most of the patients are asymptomatic. So we need not operate them. However, in certain cases, these patients need to be operated. And those scenarios or those indications are mentioned in a clear-cut manner in Sabiston textbook of surgery. They are significant history of compromise, which means that probably they are going to have heart failure or lung problems. They have difficulty breathing, so they have significant compromise, and the chest wall needs to be reconstructed for them to live a decent life. Significant body image issues. A person does not look good or does not feel good. A person gets depressed by looking at his chest and his body image issues. We can go ahead and operate. If there is significant anterior chest wall pain that is happening due to this deformity, then also we can operate. All right. And the most important thing, there are two measurements which are mentioned in the textbook. That is, if the caliper measurement of depth, if the caliper measurement of the depth is more than 2.5 centimeter, or there's an index, we don't want to go into the detail of the index, that is a Haller index. If the Haller index is greater than 3, then these are indications for surgery in case of pectus excavatum. So now let us solve the MCQ. So we have diagnosed this condition. This is a depression, and that is pectus excavatum. And the question is, which of the following are not indication of surgery for the above condition? They're asking which is not an indication. Option A, there is significant history of compromise. As we have discussed, if there is compromise, if there is problem breathing and problem carrying out activities of daily living, then it is definitely an indication. Option B, significant body image issue, if the person has problem looking at himself in the mirror or herself in the mirror, then surgery can be done to make the patient feel good about himself or herself. If there is significant anterior chest wall pain, then also surgery can be done. So option A, B, C, all these three are indications of surgery. Now let us look at option D, that is caliper measurement of depth of greater than 5 centimeter or Heller index of CT scan greater than 3. We have mentioned clearly over here that this depth, if it is greater than 2.5 centimeter, we should go ahead and operate. Or if Heller index is greater than 3, then again we should go ahead and operate. So obviously this option is not the correct answer. I mean, not the correct option. Therefore this has to be the answer, because the depth greater than 2.5 centimeter needs to undergo surgery. After we have completed this, we move on to the next question. Which of the following statements regarding pectus excavatum is false? Let us understand that if we take a cross section of a body, that is like this, we have the vertebral column posteriorly, we have the lungs here, we have the heart somewhere over here. We need to understand that this is normal. In case of pectus excavatum, this manubrium sterni gets depressed like this, and this particular deformity has a name, and that deformity is called as a cup-shaped deformity. So this is a cup-shaped deformity. We had discussed before that it is more common on the right side, but the heart gets shifted further towards left and gets rotated. So in this particular case, the heart, which is this, gets shifted more towards the left and it gets rotated. Okay, so heart gets shifted further towards left and gets rotated. All right. Next, depression of the middle 1/3 of the mesosternum. Is this the right answer? It is not correct. This is not correct. It is not depression of the middle 1/3 of the mesosternum. It is actually the depression of lower 1/3 of mesosternum. All right. So with this information in mind, we can solve the question. We have to pick out the false statement. All right, false statement. So let us look at option A, cup-shaped deformity. Yes, this is correct. There is a cup-shaped deformity. Then heart is shifted towards left and rotated. I have discussed this particular point is like thrice. So yes, heart is shifted further towards the left. as we can see over here, heart is shifted further towards the left and it gets rotated, so therefore this option is also correct. Option number C, there's depression of the middle one third of the mesosternum. This is a wrong option because there is a depression of not the middle one third, it is actually lower one third of the sternum. So since we have to choose the false statement, this is the correct answer to the question. Moving on to the next question, that is we have to identify the above procedure. All right, so for correction of pectus excavatum, there are two different approaches. One is open surgery, the other one is minimally invasive surgery. The open surgery is called as Ravitch procedure, and minimally invasive surgery is also called as the Nuss procedure. So in case of Ravitch procedure, what happens is the manubrium sterni, sternum, xiphoid, the ribs are taken into account and these are resected and reconstructed in various ways, so it is an open surgery. In case of minimally invasive surgery, as we can see over here, there is a laparoscopic port over here. Lateral incisions are given on the chest wall over here like this. Lateral incisions are given on both sides, and if there's a chest wall, lateral incisions are given and a steel rod like object is inserted. This holds the chest wall and it pushes it outwards. Okay, so therefore this is a sort of minimally invasive surgery. There is not a lot of blood loss, and this is called as Nuss procedure. So it's a very classical image that is given over here in this particular image. These are rods which are placed from lateral incisions and they pick up the chest wall and pushes it outwards, and therefore this particular procedure is actually called as a Nuss procedure or a minimally invasive surgery for the pectus excavatum. Right, now moving on to the next question, we have to identify the condition from the image given and we have to solve the question. Before we go ahead and solve the question, we need to understand that there are various chest wall deformities. One is pectus excavatum, pectus carinatum, Poland syndrome, etc. etc. If the manubrium sterni is displaced dorsally or inwards, it is called as pectus excavatum, and if the manubrium sterni is displaced outwards, then it is called as pectus carinatum. If you look at the manubrium sterni here, if you trace it, we can easily see that it is pushed outwards and not inwards. Now since the anterior chest wall is pushed outwards, this particular condition is called as pectus carinatum. There are few points that we need to learn about pectus carinatum. The most important and obvious point is the outward displacement of sternum. It is also the second most common congenital chest wall deformity. It is the second most common congenital chest wall deformity. Okay. Third thing that we need to know, that just like pectus excavatum, pectus carinatum also is mostly sporadic. However, in this particular scenario, there are a couple of varieties which are mentioned in our textbook. So we need to know about those varieties. The first variety is called the keel chest variety. The second important variety is pouter pigeon variety. In the keel chest variety, we need to understand that it is the most common variety of pectus carinatum, and here the manubrium xiphoid joint is involved. Sorry, not manubrium xiphoid joint, it is the joint between the xiphoid process and the body which is involved. And in case of pouter pigeon, it is the manubrium and the body which is involved. This particular joint is involved, and in case of keel chest, it is this particular joint which is involved between the xiphoid and the body. And the most common variety is the keel chest variety. So with this particular knowledge base, we can understand that this particular image is of pectus carinatum, and the answer to this question is pouter pigeon chest variety is the most frequent variety. This is the false statement, because outward displacement of sternum is correct. Most cases are sporadic, which is also correct. Few are familial. Keel chest variety is the most frequent variety, which is also correct. Next, we move on to the second question. Identify the variety of chest wall deformity. I've already said that this is outward displacement of the sternum. That is why it is pectus carinatum. And this has two different varieties. One is keel chest, which is the most common, and it involves the xiphoid process and the body of the sternum. And the second variety is the pouter pigeon, which involves the manubrium sterni and the body of the sternum, which is the upper part of the sternum. So here we can see that at the nipple areola complex, there is an outward, and we know that at the just below the nipple areola complex is the xiphoid process. So this outward displacement is probably at the level of the body of the sternum and the xiphoid process. It is at the level of body and xiphoid, which is lower sternum, and therefore this particular deformity is pectus carinatum but keel chest variety. This is the correct answer. The next question, we need to identify this variety. In this particular scenario also, there is an outward displacement of the sternum. Okay, since there is outward displacement, it is pectus carinatum, and since the upper part of the sternum is involved, how do we know upper part is involved? Because if you look at the nipple areolar complex, it goes upper part. Because the upper part is involved, this is a pouter pigeon variety of pectus carinatum. Okay, so option B is the right answer. Next, we have to identify this condition. Remember, in the first question we discussed that there is a condition which is called as Poland syndrome, and this particular syndrome called as Poland syndrome, there is an absence of or aplasia of pectoralis minor or pectoralis major or second to fifth ribs, or there is aplasia of the breast or nipple areola complex. There is hypoplasia or aplasia of the subcutaneous tissue. There is alopecia of the axillary or alopecia of the nipple areola complex region. There is alopecia. So with those in mind, let us solve the question. Which of the following are not seen in the above condition? The above condition is Poland syndrome. Obviously, this side of the chest wall, there is atrophic. The muscles are appear to be hypoplastic. So there is absence of pectoralis major muscle. This is seen. Either there is absence or hypoplasia or aplasia of pectoralis major muscle. This is seen. Aplasia of costal cartilage of second to fifth rib. Yes. Also seen. Hypoplasia of nipple areola complex. Yes. This is also seen. Alopecia of axillary region. Yes. Alopecia is also seen. So what about failed fusion of the two sternal halves? As I've discussed, that if the two sternal halves don't fuse, there's a gap in between, and this condition is called as the bifid sternum, and this is not a part of Poland syndrome. This is a separate entity. So not seen is failed fusion of the two sternal halves. So this is the correct answer. So with these many questions, we have concluded the topic. I hope that I have made it easier. If there are any doubts, is there anything that you'd like to discuss, then please post your questions in the comment section. I will try my level best to answer. Thank you.